Yeah, good
Good
evening,
evening, all.
everyone.
Yes.
So I
Yes.
welcome Dr. Ashok sir, who is the chief of our blood bank as well as a pathologist in Sagar Hospital, Bangalore, for today's class. Welcome, sir.
Yeah, thank you
Yeah,
for
thank you. Yes.
thank you, sir.
So he'll be moderating the today's session with me. So I request Likith to start off the class.
Okay. Okay, sir. Yeah. Good evening, all. Today is I'm Sai Likith. Today we are discussing about topic blood components and transfusion. Now, coming to the blood definition, blood is a fluid connective tissue that circulates throughout the body, consists of plasma and cellular components. Cell Cellular components comprises of 45%, in that RBCs are 43.5 and WBCs are comprises of 1%, platelets are 0.5%. And majority plasma is 55%. It contains water water up to 50% and proteins up to 4%, like albumin, globulins, and fibrinogen, and molecules of 1%, like hormones, other hormones, and nutrients and ions. Coming to the blood components, this blood components preparations was developed in 1960. It is prepared from the whole blood by the method differential centrifugation. The there are two methods, which is platelet-rich plasma method and Buffy coat method. Now, most commonly used in our India and also in our Sagar blood bank also, this is platelet-rich plasma method only. Now, coming to the
Wait,
blood
wait.
component.
Okay, you will explain what are the methods and what is the
Yes,
difference later. Okay,
yes, no.
okay, move on. Yeah.
Now, coming to the blood component preparation by platelet-rich plasma method, in this, the collected whole blood is subjected to soft centrifugation, which we get packed red blood cells and platelet-rich plasma. And again, platelet-rich plasma is subjected to hard centrifugation. We get fresh plasma and platelet concentrate. That when obtained fresh plasma is when rapidly frozen, we get fresh frozen plasma, and that obtained fresh plasma is again subjected to thawing. It means making warm at 4 to 6 degrees Celsius. We get a mixture of white flocculant precipitate and plasma, and again that mixture is subjected to centrifugation. That white flocculant precipitate and plasma get separated, and that separated materials, when frozen, we get frozen plasma and cryoprecipitate. Now, coming to the apheresis procedure, it is in apheresis in Greek word means to separate, and it is a procedure where single component required is collected, and the rest of the whole by collected by a apheresis machine, and the rest of the blood is returned back to the donor. Now, there are two working principles of apheresis. Then one is centrifugation and filtration. In centrifugation, blood components are separated based on the specific gravity. In filtration method, it is blood components are separated based on their size. Now, based on the components we separate, the name is given based on the components. In plasmapheresis, we separate plasma. In plateletpheresis, we separate platelets, and in erythrocytopheresis, we get RBCs, and leucopheresis in WBCs. In stem cell apheresis, we get stem cells, separate stem cells. Now,
Yeah, can
coming
I
to the
add something?
Sir,
yes,
yes,
sir.
sir. You can chip in anytime in between and ask him questions also.
Okay. Nothing.
Yeah.
In our blood bank, actually, we do mainly platelet pheresis. We have license to do plasma pheresis also. But as of now, we are not doing any plasma pheresis, but we are actively doing platelet pheresis. That is SDP procedure. Which
Any
is
reason
common.
why we are not doing, sir? Plasmapheresis?
Plasma pheresis, actually, there was a request during COVID time that convalescent plasma and all to prepare, but
Okay.
that time we, I mean, we have actually a license only to do routine plasma pheresis, But
Okay.
this that COVID time, that convalescent plasma separation and all, we tried to apply, but we did not get any, approval from drug controller that time.
Okay.
So
Okay.
mainly this plasmapheresis mainly in dialysis and all they do now. Otherwise, we are doing only platelet pheresis.
Okay. Okay.
Okay, sir.
Yeah, go ahead.
And that area red blood cells, if you only want to like isolate red blood cells, that can be done technically, or in our hospital it's not possible.
Not possible, sir. For that, some other different machines are there, higher version machines are there. So
Okay.
we are not having. And even stem cell pheresis and all, usually in cancer setup, they use. But the present machine, what we are having is not compatible with those techniques.
Okay. So if you have that advanced machines, you can do it in our this thing also.
Yes.
Okay.
Okay. Now, coming to the different components, various components, packed red blood cells, platelet concentrate, fresh frozen plasma, cryoprecipitate, and plasma derivatives. These are different types of blood components we separate from the whole blood.
Very long.
Okay. Now,
Go on.
okay. After collecting the whole blood, the blood components are collected in the blood bags. Blood bags are made of polyvinyl chloride that contain diethyl phthalate, hexyl phthalate. In that, preservative solutions are used, that is CPDA and SAGM, blood SAGM solutions. That CPDA is anticoagulant and preservative, and SAGM is an additive solution which adds shelf life up to 42 days compared to CPDA, which is 35 days. In the CPDA, that constituents are citrate, phosphate, dextrose, adenine. In SAGM, there is saline, adenine, glucose, and mannitol. In SAGM, mannitol prevents hemolysis. And in the compared to CPDA, in SAGM bags there is high RBC viability. It provides better membrane protection.
Actually, basically all the blood bags, they are CPDA blood bags
CPD.
only. In
In that
SAGM blood
additive
bags,
solution.
hello, in SAGM
Yes.
blood bag, why we use that term? Because in addition to CPDA, we use some SAGM solution. So after initial centrifugation, so PRBC and platelet-rich plasma is separated. After that, after this plasma is separated, this SAGM solution is added to the PRBC. So the CPDA already has, citrate, phosphate, dextrose, all this nutrient. In addition to that, SAGM also contains ADP, glucose, and mannitol, which gives additional. It acts as an additional source of energy, so thereby increasing the shelf life of PRBC from 35 days to 42 days. Go ahead.
Yes. Now coming to the various blood components, storage temperature and shelf lives. In whole blood with CPDA can be stored at 2 to 6 degrees Celsius. Its shelf life is up to 35 days. And in packed red red blood cells with SAGM, storage temperature up to 2 to 6 degrees Celsius and shelf life up to 42 days. For platelet concentrates, we store at 20 to 24 degrees Celsius with continuous agitation, because to prevent it from clotting, and it has shelf life up to 5 to 7 days. And fresh frozen plasma, cryoprecipitate, and plasma can be stored at 18 degrees Celsius, minus 18 degrees Celsius or lower, and it has shelf life up to 1 year. Now coming to the screening for transfusible transmission infections. These are the different infections we screen for after collecting the blood. This HIV, and for HBsAg, hepatitis C virus, malaria, and syphilis.
No, Likith, 1 minute. Will you
Sir.
check for this after you collect the blood or before you collect the blood?
Sir, this after collect.
Ashok sir?
Sir,
Sir,
yeah. When
this
there is a
one.
routine donation, a voluntary
Okay.
donation or replacement donation, we do these tests after collecting the blood. But when there is a SDP procedure, the kit is very costly. The kit itself costs around 7,000, and what we charge is around 11,000. So for SDP procedure, we do all these tests before the procedure, but for routine donation, we do only after collecting the blood.
Okay. Okay.
Yeah. Yeah, please go ahead.
No, yes, yes. Now coming to the
And
this
and one more thing I want to add. Please go back to the
yes,
that previous yeah.
this slide, sir.
So yes, correct. This slide only. Till last month, we were doing only TTA screening by CLIA method. So that is basically antigen antibody detection method. So recently, since 15-20 days, we started doing NAT testing also. That we are outsourcing to TTK blood bank. So the advantage of NAT over CLIA is the window period is drastically reduced in NAT compared to CLIA method. So NAT is basically PCR testing, which directly detects viral RNA or DNA, whereas in CLIA, which detects antibodies that are usually developed in the later course of the infection. So here, since we are doing NAT test also in addition to CLIA test, it detects the presence of antigen much earlier compared to CLIA.
What is the time difference, sir?
That window periods, huh?
Yeah, window period.
Yeah, usually it start detecting from 7 to 10 days in a NAT test, whereas
Okay.
especially for HBsAg and HCV,
So,
HBsAg and
so
HIV.
you mean from the onset of infection,
Yes,
like it
yes, yes.
might not be,
Window period, yes.
window
From the
period. Yeah,
starting, yes, sir.
starting.
Yeah.
So
But
other
whereas in
method?
CLIA usually for HIV and HBsAg, it is almost after 1 month only the window period, starts.
Okay. Okay.
We
So
start detecting antibodies only after 1 month. So, but whereas with the NAT testing, we can start detecting after 7 to 10 days. The main difference is with the HCV. For HCV, CLIA detects HCV only after literally 2 months. So, whereas the window period is drastically reduced to 14 days, especially in HCV. So, there is literally almost 45 to 50 days difference compared to CLIA.
okay. Okay. And cost, how much the factor?
Yeah, cost actually in additionally 1,000 rupees we are charging, but in that 1,000 also 600 will go to PRBC and 400 to plasma. So, for
Okay.
example, if one patient requires 3 PRBCs, so 3,000 additionally we will not charge. We will be charging 600 into 300. That same donor's plasma will go to some other patient. So
Okay.
it's like that. So basically, we are charging 1,000 on one unit, but 600 will go to one PRBC and 400 will go to plasma.
Plasma. Okay. Okay.
Yes.
Okay. So, now coming to the this whole blood and PR packed red RBCs and fresh frozen plasma. These three are group specific components, because in this there are in whole blood and PRBCs there are antigens on RBCs, and in FFP there are fresh frozen plasma there are antibodies. So it must be transferred only group specific only, because of transfusion related reactions. In SDP, single donor platelets and random donor platelets cryoprecipitate, these three are non-group specific. We can give for any group because there are no antigens and antibodies in this.
I mean, antigen and antibodies will be there, but they are in a
But
negligible.
antibody titer will be
The
less.
titer will be very less. So even if we
Negligible.
transfuse also, it will be diluted in recipient plasma.
Okay.
Yeah.
Now coming to the duration of transmission of different blood components. And whole blood and PRBCs should be started within 30 minutes within 30 minutes of removing from refrigerator, and should be completed within 4 hours from the starting time. If it extends more than 4 hours, discard that bag. And this platelet concentrate and fresh frozen plasma, then cryoprecipitate, these should be started as soon as possible from the issue, and should be completed within 30 minutes of the starting time.
What is the reason?
Sir,
Why
this
you should do that? Less than 4 hours.
this
What
one,
if it goes beyond 4 hours? What will happen?
because of temperature, that RBCs and get denaturated, sir.
The main thing
Okay.
is
Yeah.
oxygen carrying capacity of the RBC will decrease beyond 4 hours. Then the bacterial contamination may start, because the temperature usually we are storing at 2 to 6 degree. So while transfusing, we are transfusing at room temperature.
Room temperature.
There is a chance of bacterial, not contamination, bacterial overgrowth. So basically, plus the oxygen carrying capacity will gradually decrease.
Okay.
And all these plasma derived factors, all this, they're very labile factors, so they lose their stability if they are transfused beyond 30 minutes. So they has to be transfused within 30 minutes of issue.
Okay. Now,
Yeah, move on.
next slide, sir. Yes, sir. When any blood component is issued from the blood bank, if it is not transfused, it should be returned to the blood bank within 30 minutes of issue. With this PRBC and SDP and SDP, RDP, if we returned within 30 minutes, can be stored till their expiry date. And for FFP, if it is returned within 30 minutes, it can be stored up to 24 hours, respected respected temperatures. And cryoprecipitate, if once issued, it is not taken back, it should be discarded. Now coming to the history of blood transfusion, in 1795, the Dr. Philip Syng Psychic carried out the first human blood transfusion, but it is not documented. In 1818, Dr. James Blundell performed first successful documented human transfusion in a woman suffering from the postpartum hemorrhage. In 1991, Dr. Karl Landsteiner discovered ABO systems of blood groups. In 1939, Dr. Karl Landsteiner and Dr. Alexander S. Wiener discovered the RH system. Now, coming to the blood transfusion in surgery. Transfusion is critical in managing blood loss during surgery, which it aims to maintain oxygen delivery to tissues and hemodynamic stability and hemostasis. Now coming to the different indications for transfusion, it is when there is a significant, these are the indications, when there is significant intraoperative blood loss and hemoglobin of less than 7 to 8 gram per deciliter, and when there is coagulopathic clotting abnormalities, and when there is platelets is less than 50,000 per microliter in bleeding patients. Now, when to start blood transfusion during surgery? These are some conditions I will discuss. In coming to the first condition, based on hemoglobin threshold in a healthy adult and in healthy adult with no major diseases at less than 7 gram per deciliter, blood transfusion can be done. In cardiovascular disease, in patients with cardiovascular disease or respiratory disease, it is less than 8 to 9 gram per deciliter. In ongoing major bleeding patients, it depends on the clinical judgment of the clinician, and or may transfuse earlier before surgery. Coming to the intraoperative indications of the transfusion, when there is if there is estimated blood loss greater than 15 to 20% of the blood volume of total blood volume, when there is persistent hypotension and unresponsive to fluids, and there are signs of inadequate oxygenation like tachycardia, low SpO2 and lactic acidosis, and when in low hemoglobin values measured intraoperatively, in the organ hypoperfusion signs like low urine output and altered mental status. With these indications, we can transfuse different blood components required for the patient. Packed red blood cells are used for the oxygen transport, and fresh frozen plasma is used in clotting factor deficient patients. In platelets are used in thrombocytopenia management, and this cryoprecipitate are used when there is fibrinogen and factor VIII deficiency conditions. Now, when to stop after transfusing blood, when to stop the blood transfusion during surgery. These are the some parameters, indication parameters to stop, when to stop blood transfusion during surgery. In first condition is when hemodynamic stability achieved. That is, in hemodynamic stability achieved, we check for blood. In hemodynamic stability, we check for blood pressure and heart rate, in normal range, and no signs of ongoing or active bleeding, and adequate urine output that is greater than or equal to 0.5 ml per kg per hour. And second is when hemoglobin target in healthy adults, when healthy adults target hemoglobin achieved to 7 to 8 gram per deciliter, and in cardiovascular or respiratory disease patients in 8 to 9 gram per deciliter. In active bleeding with massive transfusion, it will be based on ongoing loss. And next, coming to the laboratory and parameters, and hemoglobin and hematocrit normalizing within acceptable range, and lactate base deficit and SpO2 improving, and normalizing normal coagulation profile values. And fourth condition, where when there is no further blood loss and no further blood loss, surgical bleeding is well controlled or resolved, and no signs of internal and extra cavitary hemorrhage, internal and extra cavitary bleeding. And avoid over transfusion, because if we over transfuse, there is a risk of transfusion related complications like transfusion TACO means transfusion associated circulatory overload, and there is hyperviscosity, electrolyte imbalance, and immunologic reactions. Now,
Sir,
coming to
Niranjan,
the sir,
Right.
Niranjan, sir. Sir,
Yeah, sir.
do you consider any other points or criteria during surgery if you need transfusion apart from the points he mentioned just now?
Nothing else, sir. Like, we basically would have an idea of preoperative blood loss. If it is an emergency, then we will consider all this. So
Okay.
generally, we tend to avoid intraoperative transfusion until and unless it's like very heavy bleeding. And
Okay.
emergencies, yes, as he mentioned, once we think the thing is stabilized, we
Yeah.
will do not tend to like overload them with unnecessary blood transfusions.
Okay. Okay.
Yeah.
Thank you.
Yeah. These are some blood conservation strategies. Then first one is preoperative anemia management in intraoperative cell salvage. This cell salvage means it is a procedure where blood loss during surgery is collected and processed and retransfused back to the patient to reduce the risk of.
Why?
Sir,
Why and when will you do this?
this one, sir. If blood is in rare types of blood groups we do, sir. That is Bombay phenotype and when blood is not available or if he has any risk prior when there prior he have any risks of he has complications due to transfusion and some disease.
Ashok sir, any other additional points, sir?
I think in immunocompromised patient, I think rarely they use. I think they do this one.
Sir, Jehovah's Witness, like separate set
Yeah,
of
yeah.
people
Religious-
who
religious
object having
intolerance.
other blood group, other people's blood.
Correct. They don't
Yeah.
take that is their religious this thing. So in those people also, and as Ashok sir was mentioning,
To
so
avoid
since it since
sensitization.
it reduces allogenic transfusion and it improves oxygen delivery, so they use it in cardiac surgeries and in say, PPH cesarean section where they need where there will be massive blood loss. You can do that. And in oncologic patients where who are immunocompromised, those patients also it like has a benefit.
And use
And
of
in and also in those patients where you anticipate massive blood loss and you cannot probably have that much amount of blood to give, as well as where you cannot give too much of blood, like to avoid massive blood transfusion, things like that. Yes, continue.
Sir,
Okay.
just
Yeah.
curious, sir. Anywhere in Bangalore, anyone is doing this intraoperative cell salvage? I mean,
I am not aware, sir.
Okay. No, just curious. That's
Yeah, I'm not aware.
okay.
Can we can any what is the requirement for this? Can we do it in like our hospital? Do we have that facility?
No. I mean, I think that requires a separate instrument, sir.
Okay.
So not just like our blood bank blood collection.
Maybe
So,
Manipal must be having it.
Must be, sir. Or some
Manipal and
cancer,
probably St.
HCG.
John's. St. John's and HCG Shankara might be having it. I'm not like particularly aware because they do all this bone marrow as well as
Correct.
all this. They might be having this kind of a facility.
Yeah, okay. And intraoperative cell salvage and use of antifibrinolytics like tranexamic acid and minimally invasive surgical techniques like laparoscopic, endoscopic surgeries and surgical precisions. Now, when a transfusion reaction occurs, then immediately stop the transfusion and inform blood bank and treating doctor, and next stabilize the patient based on the symptoms and send back to whole transfusion set and the reaction form and blood samples with containing of blood samples of EDTA, serums and urine samples.
And there is no window for retransfusion of the same blood actually. Even if the reaction is mild or minimal. So irrespective of the type of reaction, you have to stop the transfusion immediately and you have to send the entire transfusion set along with the blood bag and all the required samples to blood bank. So if required, after stabilization of the patient, we will cross-match with the new unit and we will issue a new unit. But there is no window for a retransfusion of the same blood.
Sir,
Because,
one more question. One
Yes,
more
sir.
question. So before we transfuse another blood, even if we cross match, so
Yes.
do we have to make sure that there is no like any autoimmune reaction kind of a thing, autoimmune like graft
Yes,
versus
sir.
resistance.
Yes, sir.
Like,
Once
so
once
what
we
is that
receive,
window period which you will require for that?
sir, once we receive the transfusion set, we do complete workup, sir. Actually, so
Okay.
pre-transfusion and the post-transfusion workup we do. So we initially classify whether it is a hemolytic transfusion reaction or non-hemolytic transfusion reaction. If it is most of the time, it will be, I mean, non-hemolytic transfusion reaction. So basically, you have to treat symptomatically, and after the patient is stabilized, we do, I mean, we do cross match with the fresh unit, fresh recipient blood. So if it is compatible, yes, we can go ahead with the fresh transfusion.
Likith, my question,
Uh,
how you said just stabilize the patient. How will you stabilize the patient?
Sir, based on the symptoms, sir, if he has
Oh,
any
and what do you mean based
yes,
on the
sir.
symptoms?
First, stop the transfusion and give IV fluid, sir. And again, if he has any rashes,
What IV
uh,
fluids? What IV fluids you will give up?
I, sir,
Why IV fluids?
to hemodilution.
Okay.
And if he has any rashes, rashes and pruritus, like if we give
What IV
avail,
fluids you didn't mention?
sir,
What IV fluid you didn't mention?
sir, only a normal saline only. Sir. We can.
Okay.
If he has any reactions like allergic reactions, skin changes, rashes, if we give Avil and Hydrocard, sir.
Okay.
And
What is
if
Avil
we
is a Avil is a
uh,
trade name.
uh, antihistamines, sir.
Yeah.
Hmm. And if he has any breathlessness, we supplement oxygen therapy. If he has any fevers, like fever spikes, we give the and antipyretics like paracetamol.
Okay.
Yes.
And that's it.
Okay.
Ashok sir,
Yes. Yes.
anything else,
Any
sir?
No, sir. Basically, it is a symptomatic management only. So initially, to start with, the I mean, patient should be infused with normal saline. Upon that, basically symptomatic management, sir.
Yeah. Okay.
okay.
Any till now any questions from anybody? Any clarification?
No, sir.
Oh, oh okay. Go on. Okay.
Yes. Now coming to different complications related to the transfusion. It can be divided into infectious and non-infectious.
It is
Uh,
not complications related to transfusion. These are called
uh,
transfusion reactions,
Transfusion
no?
reactions.
Yeah.
Yes, this transfusion reactions these are can be divided into infectious and non-infectious. In infectious, the hepatitis B, hepatitis C, and HIV, HTLV. These are the some common infections occur during transfusion reactions. In Creutzfeldt and HHV8, malaria and West Nile. In non-infectious, it can be divided into acute and delayed. Acute reactions occur with
Do we still get those infectious reactions,
sir,
or when will you get it? Do we still get
it
these
is
three transfusion reactions? Infectious, which you mentioned, hepatitis B, C, HIV, and all that.
no, sir. These are only less chances, sir, because for we'll screen, sir. We'll screen, no, sir, after collection and
That
these
is why I'm asking.
crewates. If
Ashok sir?
Yes, sir. There is a possibility when the blood is transfused during window period. So
Okay.
there is a possibility. For example, in NAT test earlier, I was
2
telling
weeks, you said.
the
Yeah.
2 weeks. So for example, if the donor is infected 2-3 days back and if he donates, so
Mm-hmm.
it will not be get detected in any of the tests.
Mm.
So the chances of donation is less I mean,
And this
there is a
malaria and
possibility.
all, malaria and all.
So malaria and all usually, I mean, it takes at least 1 day, 2 days, sir. It is very rare, sir. Malaria, very rare. But hepatitis B, C, and HIV, there is a possibility because many of the blood banks they do only clear testing, sir. They are not doing NAT testing. So there is
No,
a
so is there a history taken always like before
yes, sir.
they
Yes,
give?
sir. In our donor questionnaire form, there is a history related to all the sexual transmitted diseases. There is a separate column, but ultimately the donor who is donating, he has to
Donating, yeah.
reveal actually, yeah.
Yeah.
If they don't reveal and if they say no, I mean, we are helpless.
No. So if they've revealed that there is a dangerous
Yes,
behavior,
yes. Then
so you
immediately,
refuse. Yeah.
yes.
Yeah.
We refuse. I mean, we don't take blood only, and we immediately counsel them. So
Okay.
we take sample and we test for this TTA parameters. Then if it turns out to be positive, then we counsel them and we refer.
Okay. No, like if it turns out to be negative, will you take it immediately or will you wait for another like
Sir.
window period?
No, sir. Yes, sir. Till the window period is over, then only we will ask them to repeat the test.
Okay. Yeah.
Okay.
Go on. Likith.
Yeah, yes. In non-infectious, it is divided into acute and delayed. Acute reactions occurs within minutes to 24 hours, and delayed may occur after 24 hours in days, months, or even years later. In acute reactions, there are different types: hemolytic, allergic reactions, and febrile non-hemolytic transfusion reactions. Tra- Transfusion-related acute lung injury, transfusion-associated circulatory overload. In delayed
No,
hemolytic.
no,
Sir,
you explain why does that happen?
sir, next slides are there,
What is
sir,
the
about it.
next slides are there? Okay.
Yes, sir. Simply I am telling names.
Yeah.
Yeah. Delayed hemolytic and post-transfusion purpura, transfusion-associated graft-versus-host disease, and iron overload. Now coming to the hemolytic transfusion reactions, it is it may be hemolytic reactions can be acute or delayed. Its mechanism is mainly occurs to mainly intravascular or extravascular hemolysis. In intravascular hemolysis, it occurs when the recipient has pre-existing antibodies against the antigen of donor RBC. It results in the formation of membrane attack antigen antibody reactions. It activates the complement. It activates complements. Complements activation forms a membrane attack complex and hemolysis occurs. And destroy. Therefore, RBC destroys. And in extravascular, donor RBCs uh, donor RBCs interact with the phagocytes of in the extravascular organs like liver, spleen, results in the activation of phagocytes causing destruction of RBCs. Here are the some signs and symptoms in hemolytic transfusion reactions like fever, chills, fatigue, and abdominal pain, flank pain, pallor, hypotension, dark urine, jaundice, and facial flushing. That management is mainly in majority of the transfusion reactions. It is based on mainly management is based mainly on the symptomatic treatment, and in this hemolytic transfusion reactions, management is observation and symptomatic, and will give hydration. Next, next one, febrile non-hemolytic transfusion reactions. It it means rise of temperature greater than 1.8 Fahrenheit or 1 degree Celsius from pre-transfusion values. Its mechanism is mainly the mechanism is that recipient antibodies recipient antibodies react with the donor antigens. It results in the formation of result in the release of endogenous pyrogens and cytokines like interleukin 1 and 6 and 8 and tumor necrosis factor. These result in the formation of rise of temperature, result in rise of temperature. And these are signs and symptoms like fever, chills, rigors, tachycardia, tachypnea, and headache. In this, management is uh, antipyretics and symptomatic.
And yeah,
And coming,
febrile non-hemolytic transfusion reaction is the most common transfusion reaction that we encounter.
okay. Next, allergic reactions. Allergic reactions. It may range from mild urticaria to life-threatening condition like called anaphylaxis. Its mechanism is mainly type 1 hypersensitivity. In this reaction, the mast cell activation occurs and results in the degranulation of the mast cells and release of allergic mediators like interleukin 4, 5, 13, and immunoglobulin IgE.
What
In
is
the
that
science and
HSN, Likith?
sir, hypersensitivity
Referring-
reaction, sir.
No.
Yes.
Go on.
Yes, sir. And in allergic reaction, mainly signs and different signs and symptoms are pruritus, angioedema, and in anaphylaxis, in bronchospasm, stridor, cough, and edema of lips, tongue, and conjunctiva, and dyspnea. Its management is in antihistamines and bronchodilators. In anaphylactic shock, we give adrenaline. The dose of 0.5 ml of 1:1000 dilutions of adrenaline. In IM, we give IM, sir, adrenaline when anaphylactic shock occurs. And coming to the transfusion associated circulatory overload, it results as a it is a result of rapid transfusion of blood volume that is more than what the recipient circulatory system can handle. And it is characterized by the respiratory distress secondary to the cardiogenic pulmonary edema. And these recipients who are at high risk are the patients with cardiopulmonary compromise and renal failure, and infants and older patients. In these patients, there is increase of BNP, brain natriuretic peptide levels, and in X-ray we will see the cardiomegaly and diffuse bilateral pulmonary infiltrates, and different signs and symptoms are dyspnea, tachycardia, tachypnea, and in X-ray bilateral interstitial infiltrates and pleural effusion, peripheral edema, increase in central venous pressure, and hypertension. In management is mainly oxygen therapy and diuretics to decrease the load on heart, and phlebotomy may be done in severe cases. Coming to the on one point, sir. In TACO, we can avoid by limiting the number of transfusion at a lower amount, and transfusions at a slower possible rate, and administering diuretics before and after between transfusions.
Ashok sir, are diuretics recommended routinely or only in high risk cases? Hello?
Hello.
Sir.
Yeah. Diuretics, I mean, if you suspect TACO, then diuretics are recommended, sir.
No, routinely I'm asking. Whenever we transfuse.
No, sir. No, sir.
Yeah.
No.
In any routine pre-medications other than that, nothing. You can just
Nothing, sir.
transfuse.
Routine. Yes.
Yeah,
Yes.
no, there's certain this thing we have seen that people give Lasix also pre-operatively, and they will give one injection Avil routinely, all those things. So as per the guidelines, there is no recommendation for
No,
any
sir.
of that.
As per the guidelines, it is not recommended.
Yeah. Because Likith said that routinely we can prevent this by giving diuretics. That's why I asked. That question.
No, sir. No, it is not recommended.
Okay.
And in patients who are at high risk, we can give, sir, or not?
That is what. So if you're
High,
And
high risk.
high risk patients means who have cardiac failure, IHD conditions.
wherever you suspect that patient might go
Wherever you suspect,
overload,
wherever you
overload,
suspect, then
then you give
then you
diuretics.
can give. Otherwise, no. Routinely, no.
Okay. Okay, sir.
You cannot prevent by giving diuretics. In those cases, if it is due to something else.
Okay, sir.
So you basically when you're suspecting that this patient has a cardiac failure or ejection fraction is low, those people who are on fluid restriction, in those scenarios, if you have to give blood transfusion, you give diuretics and then do. Other than that, routinely, that is why I asked
Okay.
that question to sir. But
Okay.
routinely, there is no indication for giving diuretics to all patients.
Okay, sir.
Okay.
Okay, sir. Next, coming to the transfusion related acute lung injury. It is a condition of non-cardiogenic pulmonary edema, mainly due to the, sir, am I audible, sir?
Now you are in between, like your voice had disappeared. Yeah.
Oh, okay, sir. Oh. Its mechanism is due to anti-HLA antibodies and anti-neutrophil antibodies of donor blood attacks the recipient antigens. It which destroys the lung tissue. And the signs and symptoms are dyspnea, fever, hypoxemia, tachypnea, tachycardia, and same bilateral pulmonary infiltrates in X-ray. But in TACO, there will be cardiomegaly. In this transfusion related acute injury, there will be no cardiomegaly because it is non-cardiogenic cause. And management is mainly supportive and oxygen therapy. Now, coming to the transfusion associated graft versus host disease, its mechanism is mainly due to the T lymphocytes present in donor blood, which attacks the recipient tissues and organs. It is mainly seen in the immunocompromised patients. And signs and symptoms are fever, rash, pancytopenia, diarrhea, abdomen pain, liver dysfunction. And management is mainly supportive care. And it can be this transfusion associated graft versus host disease can be prevented by gamma irradiation of blood products, which destroys the donor lymphocytes. Coming to the massive blood transfusion.
Likith, 1 minute.
Yes. Okay.
Go back to the previous. That's why we usually avoid transfusing the blood from relatives, close relatives, because
Yes.
close relatives, I mean, usually blood will have a HLA which is matching with the recipient. So their HLA antigen or genotype will be matching. So when you transfuse donor blood with the HLA which is matching with the recipient blood, so donor blood has T lymphocytes. Usually it is an antigen. Lymphocyte is an antigen. So when you transfuse this, these lymphocytes, they escape the immune mechanism by the recipient. Usually whenever an antigen is transfused into any other bodies, usually if those antigens are immunogenic, the recipient body will immediately destroy those antigens. So here, since they are blood relatives and there is a HLA matching, there is a immune escape mechanism. So these T lymphocytes, what they will go and destroy the recipient cells.
Yes.
So this is what happens when you transfuse blood from own relatives.
Okay.
Yeah.
Yes.
I hope it was very clear. I think any questions, clarifications?
No, sir.
Okay,
And
more.
yes. Now, coming to the massive blood transfusion, there are different definitions. First one is replacement of one whole blood volume within 24 hours, or replacement of 50% blood volume within 3 to 4 hours, or greater replacement of greater than or equal to 10 blood unit transfusion within 24 hours. Now, coming to the criteria for identifying the coming to the criteria for identifying the patients who are at risk of massive hemorrhage. This first condition is patients who are likely to be needed replacement of their entire whole blood in 24 hours, and the patient having at least one injury, like at least one of the injuries like severe thoracic injury or abdominal injury, pelvic injury, and condition like persistent hemodynamic instability, and an ABC score of 2 or more, equal to 2 or more. ABC means assessment of blood consumption. It has four variables like SBP, systolic blood pressure less than 90 mmHg, pulse rate greater than 120 beats per minute, and with having penetrating injury present, and focused assessment sonology in trauma is positive. Each variable has point. Each variable is has 1 point. If a ABC score has equal to 2 or more, it fits into the criteria for patient fits into criteria for massive blood transfusion. Now, coming to the massive blood transfusion protocol, it is established to provide rapid blood replacement for patients with the blood loss, massive blood loss. In this balanced resuscitation should be started immediately in the ratio of 1 is to 1 is to 1 of PRBCs, FFBs, fresh frozen plasma, and platelets, and continuous monitoring of vitals and blood investigations throughout the resuscitation should be done. And coming, yeah. Now coming to when senior clinician coming to the MTP protocol and activation, when senior clinician or doctor treating the patient identify the condition and criteria which the patient fits for massive transfusion, he activates he activates the he activates the massive transfusion protocol, and notifies blood bank once the patient is identified at the massive risk of hemorrhage. And after that, blood bank issues 4 units of RBCs and 4 units of PRBCs and 4 units of FFPs, and one one therapeutic, one platelet concentrate, and the tranexamic acid should be given immediately because it prevents fibrinolysis. It should be given if it tranexamic acid should be given within 3 hours of trauma to be more effective. And during the resuscitation, continuous monitoring of blood investigations like complete blood count and coagulation profile, ionized calcium, and ABG analysis should be done every 30 to 60 minutes. And resuscitation endpoints for massive transfusion are when the core body temperature is greater than 35 degrees Celsius and a pH of greater than 7.35 to 7.45, and lactate less than 4 millimole per liter, ionized calcium greater than 1.1 millimole per liter, and platelets of greater than 50,000 per microliter, and INR of value less than 1.5, and fibrinogen greater than 1 gram per DL. If the if this resuscitation, if this criteria are met, then bleeding control, we can see is that MTP. If it is not, and again we have to transfuse the blood.
Sir, any input, sir?
Likith, can you clarify? Initially, you told that massive transfusion protocol. Come to this. Yeah, there is a balance resuscitation of 1:1 ratio, but in that
Yes.
chart, you were mentioning that 4
4 and
units
2.
of PRBC.
Sir, this is what issued by the blood bank, sir. But we transfuse in the ratio of one PRBCs and 1:1 only, sir. Base.
And one more
This
point.
is not transfusion, sir. This is issue from the blood bank, sir. MTP. And we transfuse that in the ratio of 1:1, sir.
Okay, and there is one more ratio also protocol in some blood bank. I mean, some setup they use 4:4:1. So that 4 PRBC, 4 FFP, and 1 SDP. Here 1:1:1 is 1 PRBC, 1 FFP, and 1 RDP. Okay,
Yes.
that 4:4:1 is 4 PRBC, 4 FFP, and 1 SDP. So 1 SDP is
Okay.
equal to 5 or 6,
5
5
to
or 6
6
RDP. It is like that. Okay. Yeah.
Yes. Yeah. Now, coming to the conclusion of today's class, transfusion in surgery can be saving, but requires careful judgment, and we should aim for appropriate use to balance risks and benefits, and incorporate blood conservation strategies where possible. No. Thank you,
Sir, anything to add, sir?
sir.
Hello.
Ashok, sir, yeah.
Yeah. Thank you for inviting me. It was a nice presentation, Dr. Likith. Actually, blood transfusion actually plays a very critical role during surgery or in a post-operative period. One side, it restores blood volume or maintains oxygen carrying capacity and improves patient outcome. But on the other hand, there is a risk of immunological reactions or infections or complications associated with. So therefore, careful assessment, especially by the surgeons during OT time or in post-operative period, and also adherence to strict transfusion guidelines and use of some blood conservative strategies are, I think, essential to ensure patient safety.
Okay, sir.
Yeah.
Anyone else has any questions or comments? If no questions,
Sir,
Yeah.
nothing, sir.
And last point, sir. There
Yes,
is
sir.
there is no window for retransfusion after there is a reaction.
Okay.
Yeah.
Sir, I have a doubt, sir. As soon as even if there is a mild rash that
No,
comes to the
no.
patient, we should just give the blood back. Like we should
No.
discard it.
I mean, you have to send it back to blood bank. We have to do,
Yes,
complete workup. The reaction may be very mild to begin with.
Okay, sir.
Okay. So we don't know if you retransfuse the same blood. So we don't
Okay,
know
sir.
whether that has some unknown antigens or antibodies or some allergens. It may trigger and it can result in a even fatal reaction also. We don't know.
Oh, okay,
So
sir.
even if it is mild, just flushing or just itching, stop and send the entire transfusion set along with the blood bank.
Okay,
Sir, if
sir.
it comes to you, what would be the workup from your end, sir? Like, if you find nothing abnormal, will it come back again as a
No. That
separate-
blood bag anyway we will discard because it
Okay,
becomes an open system. So when
Okay,
you
sir.
remove from the patient's body and send it back to blood bank, the temperature is not maintained, so it becomes an open system. So we discard that bag because we have to do culture from that bag. Then post transfusion, all antibody screening, everything we have to do. So it becomes an open system that cannot be transfused. So if you need a fresh, I mean, one more unit, then you will have to send fresh sample after the patient is stabilized. Then we do re-cross matching and reissue.
Okay, sir. Sir, is there a role for sample from the patient, sir? Like if the reaction is little severe, would you
Hmm.
also request patient's blood sample for the
Yes,
culture
yes.
or any test, sir?
No, that is what sir said. No, patient,
No,
they will call them for cross match again. They will take the fresh
Oh,
sample from the patient.
no, sir. What she is
okay.
asking is if
Ah,
there is a reaction, whether I mean patient sample is required for further test. That is what she is asking. No.
It is not the problem of the blood bag, but there was some problem from the patient side which caused the reaction. Is what I'm asking, sir.
See,
Like,
yeah, we do, I mean, initial workup mainly to rule out whether it is a hemolytic or non-hemolytic.
okay,
Okay.
sir.
So whenever there is a reaction, that time only, I mean, you have to draw the blood, one EDTA, one serum and urine. Okay,
Mm.
not after the patient is stabilized. After the patient is stabilized, you have to send only if you require a new blood bag.
Yes, sir.
During the reaction, or when you notice that there is a reaction happening, immediately you have to send the sample then and there only for routine workup. And if you need a fresh blood, then after the patient is stabilized,
so that is what our doubt was. So you take the patient's blood also, like you draw
yes,
blood
yes,
immediately. Yeah, that is what was our doubt. Yeah.
yes.
So immediately, as soon as the reaction happens, you have to draw the patient's
Yes,
blood and
yes,
send it.
yes, yes.
Both
I mean,
EDTA and other
from
thing.
one side you have to start stabilizing the patient, and one side you have to start sending the samples along with the transfusion set.
Any more questions? If no more questions, comments.
Sir,
Yeah, Samir. Nitya, you have question?
I don't know if it's a correct question to ask, but
Yeah,
so
ask
many
us. What is it?
times the sisters will say that patient is eating, not like even if the patient is having some other thing like eating or other albumin or something, when to give blood transfusion. So is it like contraindicated when patient is suppose patient can sit and eat at the same time, can we give the blood transfusion along with when the patient is eating? Is it like during the time of eating, we should not give blood transfusion, something like that, sir?
I
That
don't
part
think
I don't know.
I don't think anything like that is there.
Ah,
If you there is no blockade to the blood flow,
Ah,
yeah.
you can
okay,
give blood
sir.
transfusion anytime. There is nothing
Okay.
like your patient should not be eating food or patient should be NP or nothing like that. I don't think any of such guidelines are there.
Okay, sir. Because when we were in Victoria and in government setup, usually sisters will say that no, I can't give because patient is eating. Patient will be comfortably eating, but the sisters used to tell us that you should not give, you should not give. That's why I always
The
had this confusion.
reason may be they had to go and monitor them. Like if when they're eating, they may move the hand this way and it might get blocked and all those things. So it will add to their work. So since it has
Okay,
to go
okay.
continuously, probably that might be the reason why they probably refused. As far as I know, I don't think there is any such guidelines where if the patient is eating food, you should not give blood transfusion.
Okay, okay.
Ashok sir?
Yeah, same thing, sir.
Yeah.
No such guidelines. Yes.
Okay. Comments? Samir?
Sir, very nice presentation, sir. Pictures should have been better if you would have added pictures about a
What
lot of.
pictures?
Yes, sir, there was only text, sir. If pictures would have been added, it would have been better. Or flowcharts at least.
Anas?
So it was a good class. Like, he has covered all of the topics that had to be covered, and he's gone into great details to explain it also, especially the adverse reactions and that sort.
Yes.
Yes, sir.
Okay. Nikita?
Sir, it was his first class, sir, and he knew what he was presenting.
Yeah.
He did very well job, sir.
Okay. Praveen?
That's it, sir.
His flow was good, sir. He was presenting well.
Yeah. Nitya?
Yes, sir. He had put in the effort, sir. Like we had made him present multiple times. Like last week, first time I made him present, it was not
Yeah.
so organized. And yesterday we had a rehearsal with all of us in Zoom. So compared to that, there was an improvement, and we gave lot of corrections yesterday. All of it he has included, and he had done a good job, sir.
Yes, sir. Okay. Anya?
Sir, ma'am, is an emergency. There is a case in
Okay.
emergency. Sir.
Okay. Fine, fine.
And
Ashok, sir, final comment, sir?
Yeah, I think, sir, it was a very nice
Nice,
presentation.
sir. Yeah.
Yeah, yeah. He covered each and every topic actually. Very
Nice.
well.
Yeah.
Yeah.
Yeah. Good job,
and
Likith. Yeah. Keep it up. Yeah.
yes, sir.
You
Sir,
Yeah.
I would like to thank Niranjan sir. Yes, thank you, sir, and Ashok sir for making this, for helping make this with PPT and all subject.
Yeah, yeah.
Yes, sir.
Yeah.
And I also
Good.
thank all the seniors and madams and sirs for
Yeah,
making
yeah.
me.
You should make use of this thing, help, no?
Yes,
So
sir. So
good job. So you
they
have done the
supported
work, and
us.
that's why it has come out well.
Yes, sir.
So keep it up like that. Yeah.
Okay, sir. Thank you, sir.
Okay. Thank you, sir. If no more questions, I think we will conclude. Thank you. Good
Yeah.
night.
Yeah. Thank you. Good night.
Good night, sir.